This session is titled TGA VSD and TGA VSD LVOTO. There's some fairly controversial topics we'll be able to discuss at the end. And with that, I'll turn it over to my co-moderator, Justin Schroeder, my good friend, who will introduce our first speaker.
All right, thank you. So we're going to start with a case presentation from one of our stellar second-year cardiology fellows at the Cleveland Clinic, Brendan Burke.
Hello, thank you for having me, to Dr. Najim, Dr. Jacobs, Dr. Marino, Dr. Blewitz. As Dr. Tretter said, I'm one of the second-year cardiology fellows at the clinic. We'll be talking about TGA, VSD, and LVOT obstruction. I have no disclaimers. So we start our case with a 7-month-old male with DTGA, a remote posterior malalignment VSD, doming hypoplastic pulmonary valve with both valvar and subvalvar obstruction. Interestingly, also a single coronary artery with a lighting convention, a 2LR, rising from the left posterior facing sinus. You required balloon atrial septostomy on day of life 3, and since palliation has developed progressive hypoxemia with saturations now in the 60s to low 70s. And here is a subcostal view where we can see both of our outflows, with the aorta arising from the right ventricle and the pulmonary artery seen arising from the left ventricle. The pulmonary valve is seen to be doming and mildly hypoplastic. Z-score is -2 compared to the aortic valve, which has a z-score of 5.5. There's a tunnel-like narrowing in the subpulmonic region due to conal deviation and some discrete circumferential ridge below the pulmonary valve. And the peak gradient across that area is 39. And here's the atrial septum from a subcostal view, showing nice laminar flow across the atrial septum. And here's a parasternal long view, just demonstrating the doming and hypoplastic pulmonary valves with flow acceleration in the subvalve region as well. And here you can see that malalignment VSD remote from the outflows, as well as, not perfectly seen here, but suggestion of a single coronary ostium giving rise to both of our main coronary arteries. And a 4-chamber view, again showing the severe subvalvar and valvar stenosis. Peak in this view was 56, mean of 32. And so we evaluated this patient with a cardiac MRI to assess ventricular volumes as well as confirming anatomy. The EDVI of the left ventricle was 17, RV EDVI was 30, so our ratio was 0.6. And here you can see the LVOT demonstrating that posterior malalignment VSD. And you can see the degree of valvar and subvalvar pulmonic stenosis from that posteriorly deviated conal septum. And here you can see that posterior single coronary artery giving rise to both of our main coronaries. And so we did a CT 3D reconstruction to help determine surgical intervention. First, we see the anterior view with our right atrium and right ventricle. Our left atrium is posterior to the PA and left ventricle. Left ventricle outflows into the PA, RV to the aorta. And then in the more standard 4-chamber view, you can see the suggestion of a large distance between the LV and the aorta. And upon measurement, it is almost 22 millimeters. And so given the significant distance between the LV to the aorta, the Rastelli procedure was thought to be not the ideal procedure given the inadequacy of the malalignment VSD and distance between the native aortic root and the LV. And then given the poor outcomes with atrial switch, we then proceeded with a Nikita procedure. Here's the picture of the 3D printed model that was used to help with surgical planning. You can see the color coding by all of the different chambers. Eventually underwent a Nikita procedure with a VSD closure, patch augmentation of both the branch PAs. So that was done at 7 months, was extubated post-op day 1, discharged post-op day 7 after an uneventful post-op course. And at 18 months, there was no residual LVOT obstruction, just trivial aortic regurgitation and no right ventricular outflow obstruction with free PR, and no residual atrial or ventricular level shunt. And so here's just some post-op TE images. He's not quite compliant with our imaging, so this is the best that we have for now, but no residual shunting and no outflow tract obstruction, just trivial AR. And so a brief discussion, just the presence of the single coronary artery and its course with the LCA posterior to the native pulmonary valve helped delineate that the Nikaido operation was possible and probably the optimal intervention for this patient. And 3D modeling was particularly helpful to both assess the LVOTO aortic pathway and plan the surgical intervention. Intraoperatively, the posterior half of the aortic root was sutured to the LVOT without need to reimplant the single coronary artery, just to give additional detail there. Thank you to Dr. Komarlu and Dr. Suji for helping with the imaging for this presentation. That will move on to the discussion.
Great. Thank you for the great case, Brendan. And you've seen some great imaging, some great 3D modeling. You'll continue to see that. I wanted to make mention that we do have Stratasys here. They'll be set up out in the waiting area. We also have a breakout session tomorrow where we'll be doing a lot with 3D modeling for those interested.
Okay, and I'd like, as Diane Spicer makes it up to the podium, I want to welcome her back. I've known Diane for a really long time. I've learned tons from you, as I'm sure everybody else in this room has. Diane is going to be, who's one of our world-renowned cardiac morphologists. We'll be talking about the anatomy that's relevant to all of us when we try to help repair these complicated heart defects.
Thanks again for inviting me to participate, and just a reminder of what we're talking about today, transposition. And here is a list of those complicating lesions. And in this session, we're going to talk about ventricular septal defects. It's important to know that in the group of hearts that have transposition, these defects can be just as variable as we see them in hearts with normal connections. So it's probably the most frequently associated and the most significantly associated lesion with transposition. And it's important to know that they can occur, ventricular septal defects can occur in any part of the interventricular septum, so that they can have totally muscular borders, or they can extend to become perimembranous, or be located in the confines or in the muscular component of the septum adjacent to the membranous septum. The most characteristic of these defects are probably the ones that occur beneath the ventricular outlets, and those typically are associated with malalignment of the outlet septum. And the outlet septum can be deviated in an anterior superior direction or posteriorly. So the anterior malalignment we'll talk about in the next section when we talk about aortic arch malformations, but we'll focus on the posterior malalignment more in this session. So some of the areas that you can see muscular ventricular septal defects, and as I said, they have completely muscular borders. You can see them extending into the outlet component of the septum or between the limbs of the septomarginal trabeculation. And you can see that this caudal limb of the septomarginal trabeculation is reaching the inner heart curvature or the ventriculoinfundibular fold, providing a protective muscle bar for when the surgeon repairs this defect. So the conduction axis is protected. They can occur in the inlet, and the septomarginal trabeculation is well away from these defects typically, and an inlet defect is described as being behind the septal leaflet of the tricuspid valve and within the inlet component of the right ventricle. You can have them anywhere over the expanse of the muscular ventricular septum, and this heart shows us an anterior and an apical muscular ventricular septal defect. All of these hearts, again, with transposition. We can have perimembranous ventricular septal defects, some that extend centrally, and in these specimens, the caudal limb of the septomarginal trabeculation reaches the inner heart curvature or the ventriculoinfundibular fold, so that the supraventricular crest is normally inserted between the limbs of the septomarginal trabeculation, and the medial papillary muscle will be superior or anterior relative to the border of the defect. The inlet ventricular septal defects that extend to become perimembranous, again, are behind the septal leaflet of the tricuspid valve. And with these defects, you need to consider straddling and overriding of the tricuspid valve. And we'll also talk about the position of the conduction axis in a bit relative to the inlet defects. You can have perimembranous outlet defects, and in this specimen, you can see that the outlet defects extend between the limbs of the septomarginal trabeculation, and that's one of the hallmarks of an outlet defect. This specimen has a subaortic muscular infundibulum that is quite hypoplastic, but there is muscle there. And you can see that the perimembranous nature of the defect shows us that there's fibrous continuity between the tricuspid valve and the mitral valve along the posterior inferior border. So these hearts are that have perimembranous defects are at a higher risk during surgical repair for damage of the conduction tissue. And you can also see the other muscle bundle that's important in specimens is the ventriculoinfundibular fold, which is that muscle that separates the arterial valve from the atrioventricular valve. There's also doubly committed and juxta-arterial ventricular septal defects, and these defects are as a result of pore formation during embryonic development of the proximal outflow cushions. So when you think about the proximal outflow cushions developing, it lifts the arterial trunk. When they form normally, they lift the arterial trunk from the right ventricle up off of the right ventricular mass, so that that arterial valve was at a different level than the arterial valve from the left ventricle. In hearts with doubly committed and juxta-arterial defects, there's hypoplasia of those proximal outflow cushions, allowing the arterial valves to remain at the same level. So we end up with one of the hallmarks of this defect, in that we have fibrous continuity between the aortic valve and the pulmonary valve at the roof of the defect. These defects can extend to become perimembranous. This one shows us that there's a posterior inferior muscular bar protecting the conduction axis. They can also extend to become perimembranous, and they always are outlet defects. Doubly committed and juxta-arterial defects are always extending into the outlet of the right ventricle. This shows us another doubly committed and juxta-arterial VSD that shows us the fibrous continuity between the aortic and pulmonary valve at the roof of the defect, but this defect extends to become perimembranous with fibrous continuity between the tricuspid valve and the mitral valve along the posterior inferior border. And in this one, I have an image of the left ventricular side so that you can see the pulmonary valve in fibrous continuity with the aortic valve, and the fibrous continuity between the tricuspid and the mitral valve along the posterior inferior border with a fairly well-formed membranous septum in this particular specimen. And this just shows us where that conduction axis would arise and run along that posterior inferior border of the defect before it ramifies over the crest or over the septal surface of the left ventricle. So when you have inlet ventricular septal defects, this can significantly complicate the surgical procedure because they lie behind the septal leaflet of the tricuspid valve, and it's often difficult for the surgeon to view these defects behind the tricuspid valve. Also, you need to consider, as I previously mentioned, the potential for straddling and overriding of the tricuspid valve. The muscular ventricular septum in these hearts with straddling and overriding of the tricuspid valve have the muscular ventricular septum no longer extending to the crux of the heart, so that the atrioventricular conduction axis takes an anomalous, or the node takes an anomalous origin along the posterior inferior border of the defect. So that we'll look at the triangle of Koch in a minute, so that the triangle of Koch in these cases is attenuated and that atrioventricular node is moved to a more inferior position where the crest of the muscular ventricular septum meets the atrial musculature at the posterior inferior border of the defect. And when we have this anomalous node, the conduction tissue will be carried along the left ventricular aspect of the septum, with the posterior caudal rim the most vulnerable during surgical repair. And this is a normal heart. And if we look at the area of the triangle of Koch, you can see one arm of that triangle is formed by the hinge point of the tricuspid valve, and the other arm by the tendon of Totaro, which arises as a fibrous structure beneath the eustachian valve. And at the apex of the triangle is where we're going to have the location of our atrioventricular conduction axis. And if you draw a line from that star to the inferior side of the medial papillary muscle, you'll see where the right bundle branch will run and then extend down the septomarginal trabeculation. When you have an inlet muscular ventricular septal defect, the medial papillary muscle extends from the caudal arm of the septomarginal trabeculation, and the triangle of Koch, we can mark its normal borders. And because the defect is inferior to where the apex of the triangle of Koch is, your conduction axis is going to run in an anterior superior position or in a relatively normal position relative to the borders of the ventricular septal defect. When you have straddling and overriding of the tricuspid valve, we have our triangle of Koch is attenuated, and the atrioventricular conduction axis will now be in this area, and there will be a long non-branching bundle along the left side of the septum that extends to the left ventricular septum, and again, with relationship to the medial papillary muscle. And you can see from the left side where that conduction axis will emerge and extend over the left ventricular septum. To look at substrates for the left ventricular outflow tract obstruction, we can have pulmonary valvular stenosis, posterior deviation of the outlet septum, and it's important to note for the surgeons that the outlet septum contains no conduction tissue and it can be easily removed. You can have a septal bulge or a fibrous ridge or shelf in the subpulmonary region, and this fibrous shelf can often extend onto the mitral valve and often will overlie the left bundle branch. You can also have a subpulmonary muscular infundibulum that is significantly thick to cause obstruction. Anomalous tension apparatus can also extend into the left ventricular outflow tract, and this can occur with straddling and overriding of the AV valve or tissue tags from a membranous septum aneurysm. So just some of these substrates you can see here. This is a transposition with a hypoplastic subaortic infundibulum, and from the left side, the outlet septum is posteriorly deviated, causing significant pulmonary stenosis. You can see the defect extends into the inlet and the outlet components of this right ventricle, and we have a perimembranous extension with fibrous continuity between the tricuspid and mitral valves. And significant pulmonary valve stenosis, also with a bicuspid pulmonary valve in this case. This is a case that had a pretty significant subpulmonary muscular infundibulum, which can also be a substrate for outflow tract obstruction. You can see how thick in nature this is. And this specimen also had a straddling and overriding of the tricuspid valve with some of those tension apparatuses also extending into the outflow tract. Here's a tissue tag extending into the left ventricular outflow tract in the subpulmonary region, and this ventricular septal defect extends to become perimembranous. Also, you can have those fibrous ridges that extend across the subpulmonary outflow tract, and you can see this ventricular septal defect is perimembranous with fibrous continuity between the aortic valve, the pulmonary valve and the tricuspid valve, and also the tricuspid and the mitral valves. You can also see where it extends onto the aortic or pulmonary to mitral valve fibrous continuity in this specimen. It's important to note that all of these substrates for left ventricular outflow tract can also occur in the same fashion in those hearts with concordant ventriculoarterial connections. So ventricular septal defects are probably the most frequent and most significant lesion in these cases with transposition. And it's important to adequately describe the borders of these ventricular septal defects prior to surgical repair so that the surgeon knows exactly what he or she is looking for when they get in there to repair these cases. Also, the geography is important, and that's described relative to where the defect lies within the right ventricle. Defects with septal malalignment also produce an additional surgical complication or surgical considerations. Thanks for your attention.
Outstanding, Diane. Joining us virtually from Philadelphia is Dr. Meryl Cohen. Many of you in this room know Meryl. She is a professor of pediatrics at the Children's Hospital of Philadelphia. She also assumes the role as the Associate Chief of Pediatric Cardiology, the Director of the Pediatric Cardiology Fellowship Program, And on the side, she's just a world-class echocardiographer. So Meryl, thanks for joining us.
Can you hear me?
We can.
Okay. Hey, Chris, how are you?
I'm good. How are you doing? I miss you.
Hey, Meryl, this is Jeff Jacobs.
Other than that, I'm good. Hi,
Oh.
Jeff.
So
Good.
I have to disclose that, Meryl, I have to disclose that Meryl Cohen and Mark Bleiweiss are classmates from elementary school.
That
And
is
and
true.
that's another part
That's
of her
amazing.
introduction to go. It's actually amazing. I mean, they were in the same elementary school class, like PS something something in New York. It's pretty cool.
Yes, 115. I look much better than him though, right?
Then and now.
We're gonna have that will be the audience response question at the end of your talk.
Well, good morning, everybody. I'm so sorry I can't be with you today. Only COVID kept me away. I would otherwise be there with you. I just want to thank Jeff and Brad and the organizing committee for inviting me to speak to you today. I'm going to just briefly touch upon echocardiography of transposition with VSD. Because most of the talks really are about the surgery for this strategy. So ventricular septal defects are pretty common in transposition, as Diane has just set you up for. Almost half of the patients with transposition have a ventricular septal defect. And the way I teach my fellows is that any VSD that you can see in association with normally related great arteries, you can also see in transposition. And so using our international nomenclature, you can have a central perimembranous defect, an inlet defect, outlet defects, muscular defects. And when you have outlet defects, that can be with or without malalignment, as Diane has really nicely demonstrated for you. And since most of the rest of the session will be about patients who have malalignment defects, these are more complicated patients who typically have outflow tract obstruction. And so when considering an echocardiography, what you need to know for a patient with transposition with a VSD, you obviously need to know the anatomic subtype, including the geography where it's located and the borders of the defect. And as in some cases of central perimembranous or muscular defects, there is some chance that those defects will close on their own, and so the surgeon may not have to address them. We need to know the size of the defect to determine if it needs to be closed during the initial surgery, whether there's more than one, and whether there's outflow tract obstruction. So just to review the different types, central perimembranous defect, as you can see in the subcostal view, sits under the pulmonary valve. Diane showed this to you nicely in the specimens, and you can see it here in this parasternal long axis view as well. The direction of flow is different than you see in patients with normally related great arteries, in that it goes from the right ventricle essentially directly into the pulmonary artery. I think one of the most important things to say about this type of defect is that now that we do prenatal diagnosis in the majority of our patients, these defects can be easily missed because we tend to do our echocardiogram immediately after birth, within the first hour or two, particularly if the patient is cyanotic and may need a balloon atrial septostomy. And so the pulmonary vascular resistance is high in that situation. And so these defects may not shunt, and you may not see them very well. And so I would advocate that if you do an echocardiogram on a patient with transposition immediately after birth, then you really should look again a couple of days later before you do the arterial switch or other operation to be sure that you don't have a VSD. And of course, in this subset of patients, the arterial switch operation can be performed, and depending on the size of the VSD, that may need to be closed at the same time as well. Inlet VSDs, as Diane showed you, is often associated with straddling tricuspid valve, as you see in this apical four-chamber view here, as well as this parasternal long axis view. You can see this patient straddled so much that they needed a Fontan operation. And so really the arterial switch would be determined by how much straddling the tricuspid valve has and how hypoplastic the right ventricle might be. To have an isolated inlet defect without straddling in association with transposition is pretty unusual. Obviously, you can see it, however, in association with AV septal defect or AV canal defect. And I'll talk about that later in the single ventricle session. And then muscular defects are actually quite common in transposition, and often they are small and don't require surgery, but some of them can be quite complex and multiple. And so here you see an example of a anterior muscular defect. This patient also has a tissue tag in the left ventricular outflow tract causing subpulmonary stenosis, as you see here. And you can see that this defect, this anterior defect in the parasternal short axis view, is large and extensive. This patient also had a couple of other posterior defects. And so we chose to do the arterial switch very late in this patient after doing a banding procedure so that the surgeon would have access to these defects. And recently, this patient underwent the arterial switch with VSD closure and has done quite well. So these can be somewhat challenging to close. And here you see in the subcostal view a patient who has an outlet defect who does not have malalignment. So this is when the conal or infundibular septum is small or absent, such that you have fibrous continuity between the aortic and the pulmonary valves. And arterial switch operation can be performed here because there's no malalignment. However, because of this fibrous tissue, the surgeon has to close the VSD in this fibrous tissue between the two semilunar valves. And so surgery can certainly damage the semilunar valve. And so you really want to try to avoid the neo-aortic valve at all costs if you can, to prevent neo-aortic regurgitation in this setting. So it's very important for the surgeon to know the location of this defect. The approach will obviously be different. And then here we have the malalignment, so-called malalignment defects, and you will be talking about arch obstruction later, but I just wanted to point out that in anterior malalignment ventricular septal defects, the conal septum, it's really more rightward deviation than anterior. The conal septum becomes an RV structure, as you can see in the subcostal view up above, and in this apical 5-chamber view, you can see the conal septum is sitting within the right ventricle. In this setting of anterior malalignment, the aorta and the pulmonary artery tend to be more side by side, and this will require a fairly complicated neonatal repair, which includes the arterial switch and VSD closure. And then typically the aorta is small in this situation because of the malaligned conal septum and the maldivision of the truncus arteriosus. And so you can have arch hypoplasia, and so the arch may need to be augmented. And in some cases, particularly if there's significant subaortic conus, that area can be quite narrowed and might require RVOT augmentation, as well as we typically see when you have normally related great arteries and tetralogy of Fallot. So it's important in this setting to assess the severity of aortic outflow tract obstruction, the size of the aortic annulus, and the arch, and you'll hear about this later. And then really what the rest of this session is about is posterior malalignment defects, and now the conal septum becomes a left ventricular structure. But it's also important to recognize that in this malalignment, the conal septum itself may be small or absent. The aorta tends to be directly anterior to the pulmonary artery in this setting. These patients typically cannot undergo an arterial switch operation because the pulmonary outflow is so hypoplastic. So it's important to assess the VSD and the borders, the size of the pulmonary annulus. You can see it's quite small in this particular setting. I can't get the other clip to move on, my apologies. The tricuspid valve to pulmonary valve distance is important. It's really a surrogate for the pathway from the VSD to the aorta. And we use all of these features to help us determine if the patient is a candidate for the Rastelli or the Nakaido, as you're going to hear about in the subsequent lectures. So what findings favor the Rastelli? Well, absence of the conal septum. So when that piece of that hunk of muscle is missing, the defect is usually large in that setting. So here you see that there's malalignment of the conal septum, but there's no muscle sitting here, and so the VSD is quite large. And so this allows easy accessibility to the aorta with a baffle. If the pulmonary outflow is very small or atretic, then it's really not worth moving the aorta closer because the smaller the pulmonary artery, the closer the aorta is to the left ventricle. And then the Nikaido can be quite challenging when there is a complicated coronary artery pattern, particularly when there's looping of the coronaries, like you see this right coronary coming around the aorta. So that can make the Nikaido a very challenging operation. Echo findings that favor the Nikaido include an anterior-posterior relationship of the great arteries, as you see in this example. The pulmonary valve should be of some size so that moving the aorta will be worth it. And then if the VSD, the malalignment VSD, is small or remote, then that would be a reason to move the aorta. And then it's much easier to do when you have usual, typical coronary arteries of transposition. And just to point out the difference between a patient who has an actual hunk of muscle in the conal septum malaligned versus not, you can see the muscle impinging on the left ventricular outflow tract and the pulmonary artery here, and that the VSD is rather small here. And in this patient, in this example where the hunk of muscle is absent in the malalignment, you can see the VSD is significantly larger. Now, the surgeon can remove this tissue. As Diane said, it doesn't have conduction tissue in it, but still, these may be taken into consideration when you're considering Nikaido versus Rastelli. And why do we worry about the Rastelli? Well, because these patients can develop early or late left ventricular outflow tract obstruction, a variety of etiologies. Here you see conus, so muscle, that was sitting under the pulmonary artery, and you can see that there's a ring, sort of like a napkin ring of muscle that's causing left ventricular outflow tract obstruction in this patient that would need to be resected. The VSD, which is the pathway or the beginning of the left ventricular outflow tract, if you will, is narrowed. And in this patient, there really isn't that concentric ring of muscle, if you will, but you do see that the VSD probably started out too small, and the pathway to the aorta is quite long. And so this patient also developed outflow tract obstruction. Three-dimensional echo has really enhanced our ability to understand the variations of left ventricular outflow tract obstruction in the Rastelli. Here you see this concentric ring of muscle sitting under the aortic valve. And if you look down the barrel of the aortic valve here, you can see the ring of muscle. And it's causing this abnormal fluttering of the aortic valve, which ultimately leads to aortic regurgitation. And just to show you the complexity of the pathway in the Rastelli that sometimes occurs, here is an MRI image where you see this concentric ring of muscle, which is causing some obstruction. But you can also see just the pathway. You have two 90-degree turns by the time you get to the aortic valve. And so these patients are quite vulnerable to left ventricular outflow tract obstruction. If the patient has anatomy that is amenable to the Nikaido, you can see that concern essentially goes away. You can essentially see mitral to aortic continuity as when the aorta has been moved closer to the left ventricle. Technically, this is a more difficult operation, but it leads to essentially more normal anatomy, if you will, such that there's no real risk of left ventricular outflow tract obstruction. So all VSD subtypes can occur in transposition as they can occur in normally related great arteries, and the majority of patients can undergo the arterial switch. Posterior malalignment typically requires alternative surgical strategies. And though you've seen some really elegant 3D modeling in the presentation that was done at the beginning of this session, most criteria for Rastelli or Nikaido can really be determined by echo. Thank you very much for your time. And again, my apologies for not being with you.
Thank you very much, Meryl. That was a wonderful talk, and I'm glad that you're going to be able to hang out with us for the panel discussion in a minute as well. And we're also sorry that you couldn't join us, and we hope that you feel well soon.
Right. So
Thank you, Jeff.
Our next talk is by Dr. Galisarian, who's the medical director of the Congenital Heart Surgery Program at Medical City Children's Hospital in Dallas, and she'll be talking to us about the Rastelli procedure.
Thank you. I don't know if you can see in the red on the bottom right corner. I have no disclosures, but I actually do because I actually forgot. Dr. Nikaido was my surgical partner for about a decade. So that's one. And then Matthew, great talk. That was outstanding. I actually have echoed myself. I have a PFO, that's it. But I also echoed my dogs. Might or might not have brought them into the hospital. Okay, so I always, I feel like the further we get away from the folks that started to develop some of the procedures that we do, the less we're going to remember. And so I always like to kind of go back and kind of think about how some of the pioneers really, had either crazy ideas or great ideas to really come up with some of the operations that we do. So Dr. Giancarlo Rastelli was born in Pescara, Italy in 1930. And at the age of 15, he and his family moved to Parma, which is where he began his interest in anatomy and physiology of the heart. And when he was finishing university, his thesis was entitled Changes in the ATPase Activity of the Myocardium During Deep Hypothermia. And that was really what was the springboard of his interest in pursuing a career in congenital heart surgery. With that, he received a NATO scholarship to become a research fellow at the Mayo Clinic in 1961. And here he's pictured with Dwight Magoon and Jack Titus at the American Medical Association in 1969 when they were actually presenting their work with the Rastelli procedure. Up until that point, though, he was really well known to have been someone who could explain anatomy, pathology, and treatment options, but really not come up with any really good surgical solutions. Hence, the first conception of the Rastelli operation as he was thinking about patients who had deep transposition of the great arteries with a VSD and PS, as we've been talking about, and as Diane and Meryl so nicely illustrated for us with their imaging. But that concept came up in 1967 and yet was first performed not by Rastelli, but by Dr. Robert Wallace at the Mayo Clinic on July 26th of 1968, which is also when I was born and maybe some of you guys too. The Rastelli operation is applied for more than just DTGA VSD-PS. So we utilize that a little bit more broadly for truncus arteriosus, VSD with pulmonary atresia, or as I learned in Boston, tetralogy of Fallot with pulmonary atresia, and various forms of double outlet right ventricle, and also congenitally corrected TGA with pulmonary stenosis. In the Rastelli operation, the principles were sort of as follows. The idea was to redirect the ventricular outflows, create an intracardiac baffle that tunnels that left ventricular flow to the aorta, in this case using a Teflon tunnel, as you can see here. And you can see how long it is, and then creation of an externalized valved conduit that connects the right ventricle to the pulmonary artery. And here, this is an aortic homograft with the anterior leaflet of the mitral valve still connected to use as that gusset. Many of us who use homographs add another piece of material. As if that's not enough, in 1967, Rastelli also, whether he did this on purpose or whether these are just figure ABC in his paper, is known to have come up with the Rastelli classification of AV canal defects. But let's just look back, see what he has accomplished. 1961, he's a research fellow, got the NATO scholarship. That's when John Kirkland was the professor and chairman of the Department of Surgery at Mayo. He married Anna Anguilleri in 1964. He was skiing in Borneo, Italy. She was 19 years old. They got married. And then right after the honeymoon, he was diagnosed with Hodgkin's lymphoma. His daughter, Antonella Luisa, was born 2 years later in 1966. And despite him becoming sick and increasingly symptomatic, he continued to do his research and sadly died in February of 1970 at the age of 37. So raise your hand if you are older than 37. Okay, and how many people feel like they've accomplished nothing in their lives? Because every time I read about Giancarlo Rastelli, I feel like a complete failure. Having said that, he's pictured, this is November 11th of 1969. This is just 3 months before he died. This patient, Vincenzo Ferrante, was a 12-year-old with DTGA PSVSD, and that was his last operation. His daughter, Antonella, actually followed his suit and became a physician. She's an internist at WashU in St. Louis, and I happen to be doing my fellowship at WashU, my adult cardiothoracic training. So there you go, one more disclosure. So as Meryl nicely outlined too, the ability to perform a Rastelli procedure is largely dependent on the suitability of the pulmonary valve to serve as a neo-aortic valve, and the leaflet thickness, mobility of the native valve, the degree of subvalvular obstruction really is important, as well as the proximity of the native aortic valve to that VSD pathway. Now, if the native pulmonary valve and the LVOT are suitable for systemic circulation, then you can just go ahead with an arterial switch with or without resection of subpulmonary conus, as your imagers can help determine. But if not, then the aortic valve will remain the aortic valve. And then a biventricular repair with a Rastelli, Rev, Nikaido, or the half truncal turn procedure can be done. Again, the principles are to make sure you understand your coronary anatomy, because the ventriculotomy is going to, you need to stay away from the coronary arteries. And then you need to determine whether or not the VSD does need to be enlarged, and then create a tunnel that hopefully will be an unobstructed tunnel from the left ventricle to the aorta, and then create a right ventricle to pulmonary artery connection. I use autologous pericardium, and I usually use a homograft with a gusset, but there are plenty of other materials that people can choose. Whether it's a Dacron patch for the VSD, a Gore-Tex patch. I've seen people use bovine pericardium and other materials. And then for the outflow tract, homograft, bovine jugular vein graft, Dacron graft with a porcine valve, a Hancock valve. So the management strategy that we utilize in Dallas at Medical City Children's is, we agree with you, Meryl. Echocardiogram is enough, but it's like I tell people, I know how to get places, but I still turn the GPS on in my car. So I like a CT angiogram. Patients are supported with prostaglandin. They may need a BAS early on. And then we try to make a decision as a group in our Heart Center multidisciplinary conference as to ductal stent versus systemic to pulmonary artery shunt. And I think the CT angiogram is somewhat helpful to our interventionalists to help determine that. CT angiogram with a 3D model, I repeat a CT angiogram because usually I like to do these operations when the patients are about somewhere around 6 to 9 months of age. And that really depends on how well they're growing. I had a 4-month-old who was almost 8 kilograms, so I did him at 4 months. And then I've had other little ones that just don't grow and need a little bit more time. And then the strategy intraoperatively is ductal stent resection or shunt takedown with or without PA-plasty as indicated, because sometimes that ductal stent can creep into one of the branch PAs, usually the left. Sometimes it can actually kind of hit the inferior wall. And then, as I mentioned, the baffle of the LV to the aorta, VSD enlargement if needed. And then I like to use a valved homograft for the RV outflow tract reconstruction and a partial ASD closure. Here you can see that, Meryl, I think that was close to an image that you were trying to show, but you can see that subpulmonary obstruction, as you can also see the pathway, the VSD pathway in this apical 4-chamber view. And, oops. Can that advance? Stop and advance. Okay, there we go. And then here you can also see the pathway where you can appreciate the that subpulmonary area being a bit crowded. Might need a little AV help. I keep clicking and there we go. Okay, and then in this parasternal long axis view, you can see the VSD pathway, but I think you can also appreciate the discrepancy in the size differences between the semilunar valves. As I mentioned, we like to use our 3D reconstruction, our 3D imaging post-processing, and then print 3D models. I brought a few of them in case people want to look at them, but we have a hard model. We can sort of cut the planes that we want, and it really gives us a preview of what that VSD pathway is going to look like. And then a little soft model that if you feel like bringing a scalpel into your office, you can kind of do the virtual operation and make the incision. It's really squishy, kind of melts if you leave it in the sun. Thankfully, we've had snow and ice in Dallas, so that hasn't been a problem lately. But those are helpful, at least to me. Here's a patient who had, Jeff, what you described, that inverted coronary pattern. So you've got your LAD and the right coronary coming off here, and then posteriorly you've got your circumflex coronary with very small PA. Sometimes when the heart's decompressed, you think all your pre-op imaging was wrong, and the VSD somehow looks a lot smaller than you thought. But you have to trust your imagers, and you have to really, approach this as a team. You can actually see some of the nodular area of subpulmonary obstruction. And then here, just a demonstration of the VSD with this autologous pericardial patch. And you can see it's not just a circle, it's a longer pathway. And then again, when you have a ductal stent or if it's a shunt, you're taking that down and performing PA-plasty accordingly. And here you can see that in this particular case, that pulmonary valve, not only in the subvalvular area, but was inadequate, but very, very small and really almost no lumen there. And then I usually downsize an ASD if it's there. If it's a small PFO, I'll leave that alone. I'd be curious to know what the other surgeons in the group do. And then I try to keep the conduit a little bit leftward and make it not too tight because you don't want to pull on the branch pulmonary arteries, and you want to be able to, hopefully have an unobstructed RV output tract pathway there. I don't know why I'm having so much trouble with this. Okay. Postoperatively, we just skipped over that. You can see there's a little bit of redundancy in this pathway. The LV outflow tract is unobstructed, and then when we move a little bit more anteriorly, you can see the aortic valve right up through here. And then an unobstructed conduit into the RV output tract. We like to extubate the patients in the operating room if there's significant concerns, or at least upon ICU arrival or within the first 24 hours. I think much like our previous speakers. Post-op considerations, and this is where our intensivists are going to be really helpful. First, immediately in the operating room, we want to make sure that we don't leave any residual lesions. If there are any, they need to be addressed right away. So we routinely do post-bypass TEE. If there's any question or if there's a debate between the surgical team and the imagers, RAPA SATs, LA pressure, I don't know, sometimes can be helpful, sometimes not, because you can still have a lower LA pressure and still have something residual, especially if you're bleeding a lot. You can have restrictive ventricular physiology, oftentimes because of the large VSD patch, and that's something I learned when I was at WashU and just in the adults, the ventricular interactions that Rick Schuessler and Ralph Damiano so nicely taught me. Of course, left ventricular outflow tract obstruction, or AI, can be a concern due to the altered conformation of the LV outflow tract and the aortic valve annulus. Again, I think making sure your VSD patches is not too patchless and not too tight. And then dysrhythmias, particularly in the setting of VSD enlargement, AV block, something we like to avoid and hopefully should avoid. And I think learning from Diane Spicer and our cardiac morphologist will make us all better. And then junctional rhythm. Long-term concerns, of course, are left ventricular outflow tract obstruction and then the need for RV outflow tract intervention. A few areas of caution, if your aorta is very distant from the VSD, then you may reconsider your choice of performing a Rastelli. If the RV is small-ish, same thing, because sometimes this patch, because it is so big, can bow into the RV outflow tract, and you certainly don't want to make a small RV any smaller. And then, of course, if there are coronaries crossing the RV outflow tract where your incision is going to be, that would preclude doing a Rastelli. The group from Indiana had recently published their experience over 30 years with 47 patients with a conclusion that the Rastelli operation for DTGA VSDPS offers excellent mid to long-term survival. What they mean by that is 93% at 5 years, 84% at 25 years, and not surprisingly, the freedom from RV outflow tract reintervention at 5 years, 85%, and then at 25 years, 25%. Got to worry about conduction problems, as I had mentioned. They can occur early or late, so these are patients that certainly need to be followed. And David Barron and his team from Birmingham had taken a look, because again, it's the question, what happens to that LV outflow tract? What is the fate of the left ventricular outflow tract after Rastelli when you selectively resect the infundibular muscle? So what they found in their series of 105 patients over a nearly similar time frame of almost 30 years was late operation was safe, and most importantly, that ventricular function was well preserved in more than 25%. But in full transparency, there are no prospective randomized trials looking at all of these different types of procedures, Nikaido, Rastelli, the REV, or the en bloc rotation or double root translocation. So I think that is something that you guys are going to be talking a little bit about, Jeff and Tara, when we get to the STS database and all that. But I just wanted to acknowledge that I can't do my job without my imagers. And Dr. Preenam Thankable has been great to either talk me off the building when I think I can't do something and, you know, be the cheerleader there. And of course, our heart warriors and families like this little guy. And I'll just tell you just one little scenario with this little guy. He presented to us from an outside hospital, term baby, 3.7 kilos, profoundly cyanotic, came to us and came to our cardiac ICU and arrested. And when we were echoing, we found out he had a huge pericardial effusion. That threw us off. We drained the pericardial effusion. He's still cyanotic, ballooned his atrial septum, still cyanotic, and then realized with further imaging, once we could get better imaging, he had a restrictive ductus. So we took him to the cath lab and placed a ductal stent. And then and he's the one that at 4.5 months of age was almost 8 kilograms. His dad's a professional football player. So he did really well. He was extubated in the operating room and went home on post-op day number 5. So thanks so much. And just again, to end with the person who started all this, to stop research is to cease to live. So there you go. Thank you so much.
Thank you, Chris. That was a phenomenal talk with really some great videos and 3D models.
That almost worked.
Yeah, and 3D models. Our next speaker, we're gonna go through a series of 3 rapid talks about surgical approaches. Next is my good friend Zohair Al-Halis. Zohair wins the award for traveling the furthest to get here, coming all the way from Saudi Arabia. Zohair is one of the most well-known pediatric and adult congenital surgeons in all of the Middle East, if not in all of the world. He's the past president of the World Society of Pediatric and Congenital Heart Surgery. He's a close friend of me and my family and a world-famous speaker, and we're really happy to have Zohair travel all the way across the world to come join us in Orlando today. Zohair, you have the floor.
Thank you very much. Good morning, ladies and gentlemen. It's a great pleasure to be here participating in this symposium. You probably heard about Dr. Rastelli from Christie, and sorry. He really was a great contributor to the surgical field. And after he died, this was a published paper in the Annals of Thoracic Surgery as a tribute to Rastelli. And as you see here, he was a pioneer cardiac surgeon who developed the classification of the AV septal defect and also known for the Rastelli procedure. I had the pleasure actually of knowing him closer as there was an annual meeting in Parma held by Dr. Squarcia, an Italian pediatric cardiologist. And because of the roots of Rastelli in Parma, they used to have a Rastelli lecture. And I had the pleasure of presenting the Rastelli lecture in 2008 in Parma. That was about the Ross procedure in complex left ventricular outflow tract obstruction. And I had the pleasure at the time to meet his sister in Parma. And knowing the man is not only just a surgeon, but also a philosopher. And you can see this is one of his quotes, the truly cultured person must make himself accessible to all. Otherwise, he is a charlatan who speaks only for himself. Now to the subject. As you probably have seen several times, there are anatomic obstruction of the left ventricular outflow tract can happen because of many reasons. It can be due to valve, tissue tags, deviated outlet septum, can be a septal bulge, can be fibrous shelves, and the abnormal tension apparatus. An arterial switch operation alone may not be feasible in cases of left ventricular outflow tract obstruction unless the obstruction is dynamic. However, the arterial switch operation with surgical relief of the left ventricular outflow tract obstruction can be performed in some patients, but the results have been suboptimal because of the residual obstruction and the greater hazard for the reoperation and the suboptimal function of the pulmonary valve as an aortic valve. It's interesting that TGA with intact ventricular septum and left ventricular outflow tract obstruction can rarely happen. And actually recently there was a collaborative effort headed by the World Society for Pediatric and Congenital Heart Surgery to look at this problem practice. And this was published in the Cardiology in the Young recently, looking at the patterns of practice and outcomes of patients with TGA, intact ventricular septum and outflow tract obstruction. As you can see, is rare. 109 patients only in the EXA over 21 years. And arterial switch and shunts and Rastelli are the most common operations performed for this particular subset of anatomy. Nevertheless, the most common used surgical options for DTGA with VSD and outflow tract obstruction include the Rastelli procedure, which was introduced in 1968, and the RAVE procedure, which was introduced by LeConte in 1980, and the Nakaido procedure, which was introduced in 1984, and the De Silva, which is not very much known, was introduced in 1994. De Silva is the same who introduced the cone operation for Epstein anomaly, and he calls it as the pulmonary translocation. I think Dr. Najm is going to discuss the Nakaido procedure in the next, so I thought I'd probably mention the other two quickly. The RAVE procedure, which is in French, the Réparation L'étage ventriculaire, REV, introduced by Yves Leconte in 1980. And the principle is to do the infundibular resection to enlarge the VSD and use a baffle to close the VSD to the aorta, and then translocate the pulmonary anterior to the aorta, performing the Leconte maneuver and direct RV to pulmonary artery reconstruction by using an anterior patch. And this leaves the patient with inherent pulmonary valve regurgitation. These are just the pictures. The infundibular septum is resected. The patch closes the LV to routes the blood to the aorta, and then the Leconte maneuver for the RVOT reconstruction. Then the De Silva, which was introduced in 1994, or the pulmonary translocation, is an interesting operation, but it really requires that there must be some reasonable function of the pulmonary valve. What it entails is just this disconnecting the pulmonary valve completely from the right ventricle, something that we also do when we perform the Ross procedure, close the VSD and then translocate the pulmonary artery and anterior and sew it directly to the right ventricle. The Rastelli is, as you have seen, is routing the blood from the LV through the VSD into the aorta and then placing a conduit from the right ventricle to the pulmonary artery. And this has been probably the only procedure for this lesion for quite some time. And we have had in literature quite a long-term follow-up for the procedure. This is a 25-year experience that was published in the year 2000 from Argentina, and looked at the late outcomes of the procedure. As you can see here, the probability of survival is very good. This is looking at 20-year survival. And if you divide that into various era, you can find that the more recent era, the survival is better. But again, it looks at the incidence of freedom from left ventricular outflow tract obstruction, 84% at 10 years, and the RVOT obstruction is 25% at 10 years. Again, another publication from the Mayo Clinic by Diarani and colleagues looked at the same problem, and the conclusion is probably the same thing. But if you look at the freedom from any reintervention is really quite high, quite low, as most of the patients by 20 years would require some sort of reintervention. The disadvantages of the procedure include the fact that you have a conduit from the RV to pulmonary artery, which makes a second operation more or less inevitable. And the fact that in many times that you've seen in the video, Christine mentioned, you try and put the conduit to the left side, but most of the time it can lie behind the sternum, and this can be a hazard during the reoperation. This is contrary to what you see in the RAVE operation, actually, where there is no conduit, and with the reconstruction, the pulmonary artery is away from the sternum. And this not only a problem for the surgeons, but I think it's also a problem for the cardiologists because, as you know, some of these interventions now are done in the cath lab, either ballooning the conduit or placing a valve in valve. As you can see here, this is the valve is very close to the sternum, but if you look at the coronary angiogram, you can see that the conduit is very close to the coronaries, and placing a stent trying to get rid of the obstruction here may compromise the coronary blood flow. And this is generally considered as one of the contraindications for percutaneous interventions in these patients. So if we want to summarize the disadvantages of the Rastelli, the need for reoperation, sometimes the LV dysfunction, arrhythmias, but you can see the RVOT and LVT obstruction is really very significant. And this may lead to suboptimal long-term survival. Thinking about the procedure, and it looked like what we came up with is the fact that if we do VSD enlargement routinely and correct the baffle design, we may be able to mitigate the need for recurrence left ventricular outflow tract obstruction. And this was the publication in 2009 about our experience with routine enlargement of the VSD for the Rastelli procedure. And this is basically to avoid as I mentioned, the left ventricular outflow tract obstruction. In this publication, we had about 36 consecutive children that underwent the procedure with VSD enlargement. Then the median age was around 2 to 4 years. And this, you've seen this picture here where the VSD is enlarged and the patch is performed trying to make the tunnel adequate and not redundant, not too tense. And most of the time, there might be no intraventricular obstruction, and the VSD is enlarged towards actually the free wall of the ventricle. And I just must say that the presence of the infundibular septum is encountered very often, but it's not that easy to resect that part because it's very close to the aortic valve, and you can easily damage the aortic valve if you're not careful. So we find out that enlarging the VSD in this area is much easier, and also will probably avoid the development of heart block, which we have seen in our early experience. Looking at the patients, 24 patients were palliated before. We had some patients required atrial septictomy, multiple VSDs. 2 patients had associated dextrocardia. 1 patient with total anomalous pulmonary venous return, 1 patient with coarctation of the aorta, and 1 patient with common atrium. The RVT reconstruction was performed in most of the patients with the use of a pulmonary homograft. Occasionally, if the pulmonary homografts are not available, we use aortic homographs. And in 1 patient, we use the Contigra. Personally, I'm not a fan of the Contigra valve conduits. There was no early or late mortality. 6 patients required permanent pacemaker implantation for heart block, and most were required within the first year after the operation. You can see here the freedom from pacemaker implantation was around 82%. However, the incidence of heart block decreased in latter half in our series with only 1 patient requiring pacemaker. And actually, since this publication, there were 44 additional cases that were performed with only 1 patient requiring pacemaker for surgical heart block. There is still, of course, the need for intervention for the RV to pulmonary artery conduit, and at about 10 years, this was about 86% freedom. However, we had no patients that developed recurrent left ventricular outflow tract obstruction. This is the results by the echocardiography. There were no patients that had any evidence of recurrent left ventricular outflow tract obstruction. The median gradient across the LVOT was around 5 millimeters with a range from 2 to 14. And in only 1 patient did exceed 10 millimeters of mercury. The gradient was not higher in younger infants compared with older children, and no patients had any significant aortic valve regurgitation. We had 2 patients that had small residual VSDs and 3 patients with mild tricuspid valve regurgitation. and 3 patients who developed branch pulmonary artery stenosis that were dealt with in the cath lab. The LV function was normal in most of the patients, except in 3, and these 3 patients were older than 4 years where they had their operation. So this just gives us the impression that probably should not wait too long on the patients being palliated before doing the definitive intervention. And most of the patients were in good New York heart functional class. I must say that we were very happy with our results for this approach. But interestingly, I came across this paper from surgeons in Iran, where actually they showed the contrary to what we have done. They said the effect of ventricular septal defect enlargement on the outcome of Rastelli, and they concluded that the septal resection in patients undergoing the Rastelli or the Rastelli type operation has a substantial effect on late morbidity and mortality, something that we have not seen in our patients. Whether this is different in patient selection or bias in follow-up, I'm not really very sure, but it's something to keep in mind. So in conclusion, early and mid-term survival after the Rastelli procedure is satisfactory. Aggressive resection of the infundibulary septum to enlarge the VSD has mitigated the risk of left ventricular outflow tract obstruction recurrence. Late conduit obstruction remains an important source of morbidity and frequently requires reintervention. Thank you.
Thank you, Dr. El-Haliz. That was excellent. So I have the pleasure to introduce our next speaker. So Dr. Najm has become an excellent friend and mentor to me and is a phenomenal surgeon and a large reason that I came to the Cleveland Clinic. He is the chair of our pediatric and congenital heart surgical program and the co-chair of our heart center. And he'll be talking to us today about the Nikaido procedure.
Thank you, Justin. It's just a pleasure to be partners with you. Thank you so much for your addition to our program. So you've heard the different techniques of how we manage those patients with transposition grade arteries and VSD with LV outflow tract obstruction. So I'll add to you one or last one. Just one slide on the historical perspective. So the first description of aortic translocation was not actually by Nikaido. It was by Dr. Bix from France. And it's all about timing. But at that time, he actually published it and that was in a setup of a transposition of great arteries with mild stenosis. So, but Nikaido has popularized it, and the rest is history. Obviously, now it's called with his name. Some modification that came after that, as you've seen in this slide, that the original was taking the entire block down of the aortic valve with the coronary arteries, but then surgeons have modified it as we go along, as they went along with the different techniques. So we've heard all the reasons why we have LV outflow tract obstruction. I'm not going to go through this. So we are on the right box in the of this algorithm, transposition with LVOT obstruction D, and we'll talk about the in the final couple of slides of this talk. So it's about the Nikaido procedure. So to recap diagrammatically, so this is a transposition. So basically taking the aortic valve with its coronary arteries, whether it's intact or removed and reimplanted again into the left ventricular outflow tract. So it is removed with a bit of a muscle below it and translocated posteriorly. Most of those are actually anteroposterior relations of great vessels. So it is mainly made for those patients with AP relations of the great vessels. Then the VSD is closed to the aorta with this patch, and then the RVOT is reconstructed. So there's a Lecomte, the PAs are translocated anteriorly, and the PA, there is autologous continuation between the ventricular outflow tract of the right ventricle and the PA. And that's why it is advantageous, because you don't have foreign material, foreign valves, until later on when you have what you get usually in tetralogy, which is PI, dilated RV, you need to implant a valve in there. So you're not worried about the need of subsequent conduit replacement at a certain interval because the patient is growing. So this is basically 3 or 4 slides on a Nikaido procedure. So most of the dissection of the coronary arteries has to be done early and quite extensively, because this is where you would want to know if you can translocate that aortic root without reimplantation of the coronary arteries or with implantation. So I do this with the heart beating. You don't have to. You just take your time and dissect the entire coronary artery. This is actually a single coronary artery, as was presented by Brandon. Then, okay. So the next is separating this aortic root from the right ventricular outflow tract. And again, I do this with a heart beating. You don't need to, and make sure that the valve is below. There's a picture on the right side that shows that you could take the entire root with the heart beating, actually, without cross-clamping the aorta. A way of actually making sure that you protect the heart. You could do it with the clamp, with the aorta also clamped. Sorry, the camera is not positioned very well on this one. But then after that, when you get to the if you're not sure, and specifically on the video, there was an abnormal coronary, I wanted to arrest the heart. So the heart was arrested, and then you can just take that aortic root, very carefully preserving the coronary artery in this patient was abnormal, and it's giving it's a single coronary artery. The distal aorta was also divided, and now we divide also the main pulmonary artery, and then we perform the Lecomte procedure. Just as standard with all transposition period arteries. In this particular patient, I did not have to completely detach the aortic root from the RV flow tract. I actually just pivoted the aortic root to the left ventricular outflow tract. Then subsequently, the finishing up the reattachment of the aortic root into the left ventricular outflow tract posteriorly. And then closing the VSD, I use Gore-Tex, 0.4 millimeter thickness to close the VSD. And that just reaches all the way up to the anterior wall of the aorta. And then finally, the attachment of the main pulmonary artery or branch pulmonary arteries into the RV outflow tract directly. And basically bringing in a patch anteriorly, can be autologous pericardium or your patch of choice that would reconstitute the RV outflow tract. Now the heart is beating, and in this particular patient, as I mentioned, we did not have to, and that's coming off bypass. So basically, this is the operation. Why is it better, at least in the long term? This is how the transposition period arteries, RV to aorta, LV to PA. Rastelli procedure, this is what happens. You actually have a circuitous track to the aorta and to the PA, and that the Nikaido brings it back to where it is, so the aorta is translocated posteriorly. Now, one of the important things that we have to realize, how far you want to translocate, or in which cases are the best to translocate the aorta. And it all depends on the size of the pulmonary valve itself, because you really don't want to translocate it for a less than 5 millimeter pulmonary artery size or pulmonary valve size. So if we look at the advantages of the Nikaido, it can be, it's a superior technique when the RV is small, because you're not taking any volume from the right ventricle, as we just heard. Also, in case of hypoplasia, you can use it as a 1.5 ventricle repair, so you can add a bidirectional gland if you have the RV, which is small and it's hypoplastic, so to avoid the single ventricle. And also, when you have an LV which is far, the Nikaido is better because it's a straighter track, as well as in the case of an uncommitted VSD, you could take the aortic root itself and not have to cut the VSD, but translocate that in the pulmonary valve if you don't have a severe pulmonary stenosis. The disadvantage of Rostelli, we've talked about it, I'm not going to dwell on that. The modified Nikaido, as you would see here, interventions for the left ventricular outflow tract is fairly minimal, if any. An RVUT still, you will need to come back because there's no valve in there. Sometimes you could put a unicuspid in there. The growth of the aortic valve, pulmonary valve, is clearly present because it is all autologous tissue, or the majority of the pulmonary outflow tract is autologous, apart from the patch material. So these are some of the data that is published. This is from China, 30 consecutive patients that they compared Nikaido with the Rev and Rostelli. It is time consuming in most of surgeons' hand. We can confirm that also with the STS database, but it does give you the better physiological and hemodynamic effect compared to the Rostelli. So there is an advantage. And that's why typically it's done by experienced surgeons in bigger centers who does a lot of these cases. This is a review from Boston Children, 80 cases, transposition with LVOT outflow tract obstruction. They've had 35 who've had just an arterial switch because this probably was a septal shift. And the other ones had a left ventricular outflow tract resection. 12 had aortic translocation and 21 had Rostelli's. Again, the patients who are undergoing Rostelli procedure were more likely to require surgical intervention for LV outflow tract obstruction, less than the Nikaido group. This is a publication from the STS database. Morel and Jeff Jacobs actually were co-authors in this, Victor Morel. 293 patients who underwent repair at 82 centers in a period of approximately 10 years. 165 had a Rostelli and 119 had a Nikaido, and the Rev was done in 9 only. So if you look at the high volume centers, or the ones who does the majority of the Nikaido procedure, fewer Nikaidos than Rostelli's had prior cardiac operation. So there is always a selection bias of who gets the Nikaido, which is not unusual with these complex surgeries. You want to go with a clean field. You go in first crack at it, like the cases that I've shown. Nikaido has a longer median cardiopulmonary bypass time and cross-clamp time. Again, it's documented by the STS database. The mortality is a bit higher, but not much, 3 versus 4. Rev, at least in this report, was high mortality. And if you look at all the other complications, they are all overlapping between the Nikaido and the Rostelli's. So when we move on a little more, the double root translocation. Now we're talking about the Nikaido just translocates the pulmonary valve above. So the division is in the main pulmonary artery, not below the valve. And here, Ho from China has actually reported cases with a double root translocation, as in you take also the entire pulmonary valve complex out of the left ventricular outflow tract and bring it up anterior to try and preserve the pulmonary valve function. So when it actually works better, so you don't abolish completely, like a valve sparing tetralogy repair versus a transannular repair. So this is bringing the entire pulmonary valve forward. So again, look at the pump time, 325 minutes. Cross-clamp times 225 minutes. There's a lot of work that goes into this. You also want to put this into perspective, whether you want to do this for preservation of the function of the pulmonary valve. So this is how it goes. You take it with the pulmonary valve and you bring it to the front and you stitch it. And if the pulmonary valve is stenotic, which is by default, by diagnosis, you should have pulmonary valve stenosis. Otherwise, why would you do this procedure to start with? So you would do a monocusp with, like what we do in tetralogy photo with a transannular patch. So you just have to gauge for yourself whether you want to do this or not. I personally don't think that it's worth. and it all depends on what the pulmonary valve size is and what is the function of the pulmonary valve and the elements of obstruction below the pulmonary valve. So all these have to be taken into equation when you do this procedure. So what they found also, again, physiologic flows in the LV outflow tract, because obviously the aortic translocation part, 5 patients had competent pulmonary valves based on their data. 22 patients had mild PR, 13 patients had moderate PR. So this is how you look at it when you want to look at those patients, if you want to preserve that pulmonary valve complex or not. Now, the half-turned truncal root also is, again, this is from Japan, 14 patients, TGA with PS and VSD, and a few with the DORV. This is their median follow-up, 5 years. They have had no mortality. So this is basically what it is. They take the complex of the aortic valve and the pulmonary valve taken in one block and turn it around 180 degrees and reimplant it. The aorta becomes posterior. You obviously have to take the coronary buttons out and reimplant them again, and you need to reconstruct the root where they came out from again. So, and I want to point out that this is their entire series. If you look at their ages, and if you have here the ages that they do this, so it's not, majority of them are actually beyond the first year of life. And if you look at the PA aortic diameter ratio, it's anywhere between 0.5 to 0.6. So you cannot, or you should not be doing any of these relocations if you have a very small pulmonary valve, because it's not worth it. You got to have a higher relation between the aortic valve and the pulmonary valve. So this is what they have depicted. So the aortic PA aortic ratio, if it is 30% or less, that means if your pulmonary valve is so small, or it's 5 millimeters or less, there's no point of translocating the aorta posteriorly. It's only small, so you just basically do a Rastelli procedure. Now, if you have it between 30 and 80%, this is where you start getting into a Nikaido, where you can have an advantage of the aortic translocation on the left ventricular outflow tract. And if I guess Siri is participating in that. So, and now they recommend that the half-turn truncal switch can be done all across from 30% to more than 80%. This is their recommendation. I would say, I think there's a good sell for the Nikaido when it's between 30 and 70 or 80% of the aortic valve. Beyond that, there's no point of this. You need to always do just an arterial switch with some LVOT resection, because that is the much better route, likely as the pulmonary valve is a good valve. And this is basically a diagrammatic showing of when you translocate the aorta posteriorly. If it's severe PS, then you've got obviously very little distance to travel, which is that you want to question whether it's worth it or not. If you have mild to moderate PS, this is where you want it. And the other thing is you want to weigh in is if you got mild to moderate PS, you got a VSD, when are you going to operate on these patients? Because they will not have severe enough restriction of pulmonary blood flow. So you have to operate them early rather than late. Or also you may actually not be able to do the proper procedure on time. So this is where a balance between the severity of the PS and the timing of surgery and the complexity of the operation you want to choose for that particular patient comes an important choice for the decision making. Very quickly on the CCTGA, it's not our topic, but I think I wanted to bring this up. So obviously, again, there is a place for a Nikaido on a generally corrected transposition. So we know all the reasons for the obstruction. It is very important to understand that you've got an abnormal course for the conduction. And this is an area which is exactly below where you would actually cut. If you have a VSD, you would cut. You don't want to cut across that VSD to enlarge the left ventricular outflow tract, because then you're going to get that conduction system out. But if there's an ability to take it out and put it into the left ventricle without cutting, this is a report of one case, basically. That's what it is. I'll stop here. Thank you so much.
So we have a little bit of time for a panel discussion. I'd like to ask the speakers from this session, Dr. Najm, Dr. Zohar Al-Halis, and Diane to come back on up. And before lunch, we'll spend a little bit of time asking a few questions. I know there's also some questions in the virtual chat room that we'll get to. And I think Justin's going to lead us off with the opening question while other people potentially formulate some thoughts. Dr. Tretter.
Right, so Hani, can you guess what I'm going to ask?
Yeah, about the conduction system.
Exactly.
You bet. I know you.
So we have the expert of the conduction system walking up to the microphone.
Actually, I was going to ask Diane about it, but go ahead.
So the Pediatric Cardiac Critical Care Consortium, say that 3 times fast, they published in 2019 that Akash was actually senior author in JTCVS, all the incidence of heart block and need for pacemaker and all the common congenital lesions that we deal with. The top 3 lesions are the Nikaido, VSD creation or enlargement, and then we'll be speaking about tomorrow congenitally corrected transposition. So the incidence was about 26% for the Nikaido, 24% for VSD creation enlargement, need for pacemaker 16% and 11%. So how are you avoiding this issue?
Technically, I think if I were to enlarge the VSD, I like to do the VSD enlargement through the tricuspid valve and not through the ventriculotomy. Because typically surgeons have the ventriculotomy. They don't need to open the atrium because there's no ASD to close, and they can close the VSD from. The problem is when you end up doing it from the ventriculotomies, you don't have that right exposure of the septum, anterior septum, to avoid the conduction system. So the best thing is to go through right atrium, tricuspid valve, put my forceps through the VSD anteriorly. Literally, first cut is below the aortic valve, which is anterior, and this is how you can avoid the conduction system, at least I would say in transposition. In corrected transposition, then it's a much bigger problem, I would say. And I think, I don't know, Christine, you want to add something to this?
I'm shaking my head because.
You do the same thing.
And I think that last image you showed with the conduction system tells you exactly why.
Exactly.
So, almost anywhere you go.
You go.
Diana will tell us how to.
Well, I mean, would that satisfy your answer?
And that goes for the Nikaido as well, the same.
Well, for the Nikaido, no. I think for the Nikaido, you're anterior anyway, because when you excise the aorta itself, you actually cut through that superior margin of the VSD. And supposedly, if it's an outlet VSD, your conduction is below that VSD, not above. So you should be okay. But if it is a far VSD, then you're going to get the conduction system above it, and if it goes above it, then you're into heart block territory.
Yeah, and I think Diane can expand about that. She emphasized the importance of understanding the borders and VSDs, and that is specifically tells us where the conduction system is. And before you speak, I'd also say Hani's well aware, but we have work coming out, Diane and I, to show how the common depiction of the left bundle going down from the membranous septum down to the apex. Instead, we know now that it often has more of an ascending course and becomes much closer to the nadir of the right coronary leaflet. In the normal heart, on average, only 3 millimeters below the right coronary leaflet.
Diane, I have a question for you. So in straddling, first of all, can you separate straddling from override, or they're always together? Why I ask this, because you mentioned also when you have a straddling override also that the triangle of Koch is smaller, shallower, and the conduction system is shifted inferiorly. Is there any way that we could figure this out? And what's the degree of, because sometimes straddling is not an all or none phenomena. There could be sometimes an attachment of one cord on the crest of the septum versus an entire pap muscle that comes out of the other ventricle. And also the override, sometimes it is like 10%, sometimes it's actually substantial, because that plays into the biventricular conversion that we're going to plan if we were to plan something like this.
Yeah, I think that I agree that you don't always have to have straddling when you have override.
Okay.
Because the one specimen that I showed, I didn't have any really good specimens that showed straddling and override, but the one specimen that I showed had override, but there were no tendinous cords extending into the left ventricle from that tricuspid valve. But the defect extended into the inlet component of the right ventricle. So that's when you get the repositioning of the atrioventricular conduction axis and the attenuation of the triangle of Koch. So I don't think surgically it will matter what you have to move, whether straddling and overriding are together. But I think the conduction axis is probably pretty much set in that attenuated triangle of Koch, and where your muscular septum meets your atrial musculature, that's where your conduction axis is going to be. And, if you think of straddling and overriding like riding a horse, if you ride side saddle, you're overriding, but if you ride regular, you have a leg in each ventricle.
Wow, the horse riding analogy of straddling and overriding. That's a new one to me, but I like it.
I like it a lot.
That's very good. But I'd like to shift this discussion a little bit because we're talking a lot about some really technical points, which surgeons could talk about for 9 days, about strategies to avoid conduction tissue and where to place the stitches. I'd like to think a little bit about counseling the families when their young children have these problems and what we tell them, because this is a challenging problem with long-term implications and potential for multiple reoperations. I'm actually going to ask if Dr. Fricker would come to the microphone and tell us a little bit about his thoughts when he's a family, because he's cared for kids for quite a while. Tell us your thoughts about patients with TGA, VSD, PS, and you're meeting with a family and you're getting ready to tell them what they're getting into, whether they're going to have a Rastelli or an Akaido or what. Dr. Fricker is our chief of cardiology here at UF, and he has a lot of experience caring for patients over the longitudinal spectrum. What do you tell these families?
Actually, Jeff, I'm probably the wrong person to answer the question because we have some fetal echo folks here that really do much more of the fetal counseling. But I think that one of the biggest issues we face with families is that it's really very hard to explain that to them. All they want is they want their child to be alive, and they will do anything for us to do something to palliate that child, for that child to survive. So I think that's a very hard thing to explain to families. So if anybody has some better ideas about that, let me know.
Well, so let me ask you another thing. Sometimes we sit in a conference and we say, here's all the advantages of the Rastelli. Here's all the advantages of an Akaido. And this family might have one or the other. And then somebody says, well, let's tell the family about both and let them choose. How do you do that?
No, I don't think you can do, actually, you can't do that.
Yeah, can you?
No, that's impossible to do. So I think they just want you to make the best decision for their child. But knowing the risk, I think it's an incredible hard thing for families to really comprehend.
Oh, yeah. Thanks.
Jeff, can I add something to that?
Yes, Meryl Cohen from the
Can you see
virtual
me?
Philadelphia Zoom. Yeah, we can all see it. It's pretty impressive, actually. It's
So you can see that I just have alcohol behind me. That's how I deal with these problems with my kids.
outstanding.
No, what I was going to say is I agree. I don't think you can leave that up to the families. I don't think that they can understand the implications and the subtleties of what, even we have trouble understanding the subtleties of these operations and what they mean. So I think it's a huge burden to put on the families. When I talk to families about this lesion or, any lesion really, I say that, you're going to have an initial operation to take care of this, but that there are, potentially long-term consequences of what we do, and that we never, except in very rare circumstances, do we make the heart normal again, and that there are things that we're going to have to pay attention to as time goes on. And I usually set them up to expect that they will need additional procedures moving forward, so that when the time actually comes that they need them, it's not so surprising to them. And for the most part, I think they're very accepting of that.
Thanks, Merrill.
Ahmed Alwi, Saudi Arabia. So I just want to ask Dr. Hani for any coronary limitations, any coronary pattern limitations for Nikaido? Like
Yes. Yes, there is. So if you have a major coronary artery that runs exactly below the aortic valve, you can't do a Nikaido. Which if you have, let's say, an RCA that gives the LAD that runs few millimeters below, at least in my hand, I wouldn't do it. I wouldn't even risk it because this is going to run exactly where you're going to cut below the aortic valve. And that's, to me, is an absolute contraindication for a Nikaido. Would you agree with that?
Yeah, and if any looping, like anterior looping, do you think?
I think the rest is the judgment call about the surgeon who actually wants to do it. I think most of these can be tackled in the operating room, but you got to be open to reimplantation of the coronary buttons. Not every time that you could relocate without reimplantation. So if you're open to this, and I think the trick in the Nikaido is to really dissect the coronary arteries all the way into the groove. Once you do this, then your margin for mistakes or kinking becomes less and less as you do this, because then the coronary arteries are not tethered to the myocardium in the groove.
I'm sorry. The second one is also any limitation due to the extreme small size of pulmonary valve, and because if it's really very small, I don't know how is the LVOT going to be like. Is it the alignment of LVOT after translocated the aorta posteriorly?
Yeah, I mean, as I was mentioning, if it's very small, it's not worth it because then it's almost aligned. So if you have a 5 millimeter pulmonary valve, my problem with that evaluation, I want to ask Merrill about this actually, is that not unusual because of the crowding below the valve. We're not able to evaluate the pulmonary valve itself, whether it's actually suitable or not for a transposition, for even a switch and a VSD closure and a subaortic resection. And I find the evaluation of the sinuses are more reflective to me rather than the actual valve because of this crowding. Merrill, could you comment on this?
Yeah, I think it's just like with everything else, to some degree, it's about what the annulus size is, true annulus, not true annulus, whatever. But what we measure as the annulus, there's just a limit to what that could be to have a successful arterial switch, right? And as you said, when the pulmonary valve is very, very small, it's not worth doing the Nikaido because the alignment is the aorta is closer to the LV already. But I think it's a combination of the conal septum malalignment, which can be resected, the size of the VSD, the pulmonary annulus, and what the leaflets look like. And often the leaflets are very abnormal, so they would not be amenable to an arterial switch anyway. Is that what you're?
Yeah, but I mean, the imaging is not. What's your best imaging for a pulmonary valve with subpulmonary obstruction? The problem is the ability to evaluate the quality of the valve is very poor in the presence of a subaortic obstruction, which you can sometimes peel and end up with a good pulmonary valve, my experience after exposure. And the way I look at it differently is I actually look at the sinuses. If you have good sinus formation in the pulmonary valve and the pulmonary artery, then likely the valve is not a bad valve in general.
Yeah, you have to look at the leaflets too, and whether they're bowing, whether they're thickened, which they often are. So I think it's a combination of all of those things.
Yeah. One question to Dr. Hare, please. I'm talking about a case I faced. Like we did a rev, then when I just tried to after LeCompt, I found it really difficult to bring it. So I had to put a conduit. Like, do you think like it was like really a proper technique? Because I felt like we taken the disadvantage of almost both. We did rev LeCompt, then we had a conduit.
Yeah, but I mean, even within a Nikaido or the RAVE, if you want to use a conduit, there is no contraindication. But the principle is that they make it simpler without having to use a conduit. But if you want to use a conduit, you can.
Yeah, conduit even with after Lecompte.
Yeah,
We
yeah.
couldn't really pull it down the pulmonaries.
So you dealt with the situation. I think that's acceptable. Yeah, there's no problem.
You could do two things. Did you resect part of the ascending aorta? Because when you resected, you could take it backward.
Yeah,
That's
that-
one.
yes.
Two, did you mobilize enough of the branch PAs?
Yes,
Because if it's still taut, then you can't bring it to the RV. That's the other
Yeah.
thing.
I'm sorry if the chairman allows me. I just want to ask Dr. Hani for one technical question. I faced in Nikaido. After taking after finishing the aortic thing, when I put the conduit in the RVOT, the lateral sides of the RVOT ventriculotomy, I found out it's not the conduit doesn't really fit. So some bleeding can happen from the lateral. Do you have any special technique just to
Yes.
avoid this?
Yes, you can put an entire patch on, because you're right. The problem with that is not like a tetralogy when you do a transannular patch. The problem is you've got a VSD patch that hooks up to the aorta, which is like a triangle, and your conduit or your PA is not actually a conduit, especially if you put a conduit. The easiest thing is to put an entire patch, close the entire RVOT, and incise that patch and put the conduit through.
Yeah, good idea.
That would
Thank you very
sort
much.
everything out.
So we have one online question and then we'll end the session. So from Sarab, how does the bidirectional Glenn work in 1.5 ventricle repair with Nikaido when there is severe pulmonary regurgitation?
I would say is that to me? I guess
I believe so.
it's a Nikaido. So you would want always to have, which is a very good question, you would want to have a competent pulmonary valve in a 1.5 ventricle repair, but not always. Obviously, you do have, what's going to end up having is a pulsatile Glenn because you have PI. Having said that, it depends on what age you do it and whether you want to add a monocusp to that at the early time. Another trick that you could do if you have a pulsatile Glenn is to band the RPA proximally before the Glenn, so you don't allow that high pulsatility in the MPA to go into the Glenn circulation. So one little trick that can be done.
I think that's very important because I think a pulsatile Glenn can also lead to long-term complications, aneurysm
Yes.
formation in the SVC. I actually personally I had a 10 centimeter SVC aneurysm in a patient
my
with a pulsatile Glenn.
Yeah, can happen.
I'd like to thank the panel and all the speakers for a great session today. Thank Meryl for zooming in from Philadelphia. And I think both of these two sessions this morning were outstanding. We're now going to take a little lunch break where Cleveland Clinic and University of Florida will provide everybody with steak and lobster and champagne. And then after that, we're going to resume at 1:15 for the next session. Thank you, everybody.